So, Enrico, can you hear me, Enrico?
Yes, yes, I
Yeah.
do.
Yeah. So, I think we are on time. It's almost 3:30. So, we will start the proceedings. I think people will join us gradually as we proceed. So, I'll just introduce you to a few of the key speakers for today's webinar. Uh, just a minute.
Hey.
Hi, Raghuveer.
Hi, Roshan.
I'm just trying to get to YouTube live. I think YouTube, there is some problem.
But it shows we are live on YouTube, Roshan.
Yeah, it shows here, but you know that is not
YouTube
moving there.
Okay.
It's not moving there.
Hi Sanjay, hi Raghuveer.
Just a minute, I'll get it done.
Hi, Umesh.
Give me time. 2 minutes. So, Enrico, for today's
Yes,
meeting,
tell me.
we have many faculty with us. So I think I should start the meeting so that we can be on time because the meeting was supposed to start at 3:30. So let me introduce today's moderator, Dr. Saurabh Mathur.
Yes,
Saurabh Mathur and Dr. Karthik Selvaraj. Are you there, Saurabh, Karthik? So I think they are not joined. So I'll request Dr. Umesh Jadhav to moderate time being. Umesh, can you take
sorry,
the
but when you
responsibility?
speak, I hear properly.
Yes, no.
Yeah, I think Dr. Umesh Jadhav will moderate today's session. Then we have two speakers, Dr. Enrico Garvasi and Dr. Raghuveer Reddy. And there are first talk is by Dr. Enrico. He's going to speak on biceps anatomy. Second is different types of bicep tenodesis. Again, Dr. Enrico will enlighten us. Third is by Dr. Raghuveer Reddy. He's going to speak on intra-articular and groove tenodesis. And fourth again is subpectoral, transpectoral tenodesis by Dr. Enrico. And this is going to be a very good session on bicep because bicep has always been a neglected area in shoulder pathology. So Umesh, I request you to take on behalf of Dr. Karthik Selvaraj and Saurabh Mathur as they join. Okay, Umesh?
Yeah,
you can
okay.
start the program.
Yes, good afternoon, everybody. May I request Dr. Enrico to have his first lecture on anatomy of the biceps tendon. Can you just unmute yourself, Dr. Enrico?
Yeah. Enrico, can you share your first
do I
talk?
start the
Yes.
You can start with your presentation.
Okay. So thank you for everything, for the invitation. And this is a very pleasure to be with you from so far from Italy, and in this moment that is very problematic with the pandemic. I hope you have not the same disaster as we do. However, we are, and this is so important, and we can connect, and this is also. Before starting the presentation, I will introduce the park in very close to Venice. The Monastir di Treviso is the city, and this is just for arthroplasty and arthroscopy dedicated structure. This is the theater I work in. And these Andrea Tomasi, Giacomo Sabbioni, Giulio Vini, the main partners of me. The most of the images are not by me personally, but from friends of me and mostly from Barcelona anatomists. I have friends there, and we, as Italian arthro in the past, most of the courses, anatomic courses in Barcelona. So this is the long head of biceps we took off the humeral head, and we can see as the fibers, as the biceps fibers, they come from a labrum. And so the fibers for the long biceps can be different. Mostly it is from the posterior part. So most of the fibers normally in the most specimen, they come from the posterior labrum. Sometimes we have a contribution from anterior and the posterior part of the labrum, and very seldom the anterior part is the one that contributes with the most of the fibers. The long biceps attachment, so the anchor, is very in individuals. Sometimes it is not fully attached. There's some meniscoid part or some small free part of the anchor. And this gets in confusion sometimes when we see the MRI or when we see in arthroscopy. So we tend, in the past, we attempted too many slap because we considered it as a slap 2 lesion. We fixed too many slap lesions that were not true slap lesion. What happens that since the soft tissue has some flexibility, and fix that flexibility, you have a stiff shoulder, and a stiff shoulder is not ideal or not well in for sports, and this is one. So here the head, humeral head, anterior cuff, the deltoid is reflected. So we detached the deltoid from the humeral insertions. This is the coracoid, and this is the conjoint tendon. So anterior, posterior, anterior, and the interval. What we see, what can we know, that there is a very close relationship between the interval and the interval the long biceps is running, and the coracoacromial arch, and this can be cause of pain. Here the circumflex nerve coming from posterior, spreading out to the deltoid in several branches. This is very far from the groove, the entrance of the groove, but very close at the distal part. And this is important to know, that if we want to do tenodesis, see, if we want to work about the intertubercular groove with the upper part, we are safe. There's no any risk. But if we would make some procedure distally, as close to the pec major, we can have some problem, and so we have to properly learn the anatomy to make that. So here we detach the coracoacromial ligament and we see the groove for the biceps. This is distal, this is the subscapularis, this is the lesser tuberosity, and here back the greater. So we see as a sagittal view, and in this we can see the greater tuberosity and the bicipital groove. The anterior circumflex coming from medial spreads to give rise to two main tendon branches. And these two branches, they fully stay close to the intertubercle, and they outline where the intertubercular groove and long biceps are. So inside this groove can be some pathology sometimes, as synovial pathology. The friction is mainly at this level. Synovial pathology can be everywhere. So biceps glides in between lesser and greater tuberosity, and the can be spikes or can be the space narrow, either narrow or not. And when constitutional or acquired modification, we can have a pathology of the biceps. We know that this tendon enters the joint, and this is unique in the body. So one tendon outside the joint that enters into the joint, right into this under the coracohumeral ligament. It's and here you can see it. So subscapularis, this is the scapula. This is biceps. Here the path of the long biceps, and here the entrance into supraspinatus is here, and here this very thick anatomic structure made by several ligaments and several tendon expansion, they stabilize the biceps. So it is not the biceps gliding, really in real is the humerus that is gliding, climbing onto the biceps. And this is the very large space that can be narrow, and the stiffness can be given for any pathology. So here another image. This was made before the Itoi. Itoi stated that the supraspinatus tendon gives fibers that go to be inserted at the lesser tuberosity. And there's the transverse humeral, and here so pulley is made by the superior glenohumeral ligament, giving a hammock for the long biceps tendon. So you see here in the relationship between the part, the merging part from the joint to outside, the sheet is off, and how it can be related to the coracoacromial arch. coracoacromial ligament, coracoacromial arch. This major, and because after in the movie that shows the Tenodesis, the biceps is a fundamental landmark to locate the long, the pec major is the fundamental landmark to find the long biceps and to fix the long biceps. So look at pec major, ascending fibers that sometimes are very steep ascending, that go to the lateral part of the greater tuberosity. So medial to the insertion of the long biceps, we can cut the groove, and you can see how the long biceps is running there. We cut it, and we know the relationship biceps and latissimus dorsi muscle. So look at here the subscapularis. These are the sisters. So they outline the 2/3 upper of the subscapularis and the malleus part, that the one that is called the subscapularis minor. And here the biceps. So when you have to fix the biceps, you can go under, so distally to the pec major, or just up to the pec major, or you can stay, and this is what I will show you, at the level of the pec major in this part. So this is the entrance. We'll cut the spinatus, or when you have a supraspinatus tear, large tear, the biceps can be loose. This is the subscapularis, and the widening, the thickening of the biceps, that some author says that it directed to the bicep function. It is not that for sure, because we never have a similar hypertrophy of the muscle of the long biceps. And this is the MRI. We often can have into the biceps groove some fluid. Some fluid is for articular pathologies or for biceps pathologies. We cannot definitely know if one or another, but in a clinical exam we can detect if the biceps is the problem, or there's some intra-articular problem as a synovial arthritic changes and so on. Now, what I would say is that this entrance of the biceps to the groove should be explored by the orthopedic more than by a radiologist. We orthopedics, we know, because we have the follow-up, we have a confirmation or not in arthroscopy if what we suppose by imaging is in the real. So I want to say and take off message that an orthopedic surgeon should be practiced, trained to ultrasound to ultrasound diagnosis. This because he can do many procedures, many non-invasive as fluid withdrawal, as exact needling or exact injection of the cortisol injection exactly where there's the problem. So all the pathologies that are pathologies often for the athletes are the ones that are given by relaxation of and distension of the superior glenohumeral ligament, whether the or by breakage of the glenohumeral ligament, and going up with the more so by subluxation of the biceps or luxation or dislocation of the biceps with a curved subscap, or as Laurent Lafosse demonstrated, the supraspinatus. So the veins of the biceps can be broken, and you can have during the movement clicking, popping, and so the clicking that is painful. Internal impingement. This is an internal impingement after the presentation I can show. This is athlete. This is a swimmer. The lady is a national swimmer with a painful shoulder. And this because in internal rotation, you have the long biceps squeezing the pulley. This is what happens now. Before it was without fluid distension, and here is with fluid entire part. This is the insertion of supraspinatus. This the pulley. This the bicep. And look as the bicep is squeezing, and the pulley, and the pulley is torn. This is a very demanding problem, because you cannot do a suture. In the past, we did a suture. The painful biceps gets more painful, more stiff. So no other chances of other than tenodesis. You know, of the very numerous tests, clinical tests. Many of these are sensible, but not really specific for the biceps. It is in many times along with the rotator cuff. So imaging, and you can by ultrasound test actively if there's some stability or some and the other are not really so specific. But so even for the to indicating the slap lesion. So many times you have a refer of the radiologist. This is for sure a slap lesion, but sometimes you have some that is not be, or it cannot. But you too often have a report from the radiologist that there is a slap lesion. And this is what happens So this is here of the proximal part of the humeral part of the subscapularis tendon, and here the tear of the biceps pullae and the subscapularis that is divided, split. So, very seldom you have isolated coracohumeral tears, but in these cases, no way. You have to fix the biceps. So you cannot repair and maintain the biceps with no risk of painful shoulder. We know that the isolated biceps rupture is in 2% of the entire amount of biceps tendon rupture. This is the how, just to show that the biceps lesion many times in sports guys, they come with other lesions. Here in the crescent part, there's a fraying, and here there's a real slap lesion. This is volleyball, and so you can have mixed, so not just the biceps, but the biceps in the interval process. So this is my shoulder team in Monastir di Treviso. And these are young guys, but very active in the society, in the Italian society of arthroscopy, in the Sia Gascot, the new society we founded joining the Society of Arthroscopy and the other big society, Italian society. They work with me. They are able to do more than I can do. I'm very proud of them. Okay.
Thank you, Enrico, for a wonderful presentation. Is there any question on anatomy of biceps and the bicep-labral complex around the shoulder joint? Anybody wants to ask any question to Dr. Enrico?
Or we.
Hello. Yes. Enrico, I have a question.
Yeah.
Regarding the anatomy which was described by the Japanese group. When they say that the supraspinatus tendon gets attachment from the tuberosity, and some fibers, 15 to 20% fiber, they come from the lesser tuberosity, creating the superior part of the bicipital pulley.
Yeah.
Hello,
Yes.
Enrico?
Yeah,
so,
I am.
So does it mean that every supraspinatus tendon tear, where you see a tendon tear, anterior fibers, you are dealing with the disruption of the superior part of bicipital pulley, and it warrants and bicep tenodesis?
Yes. So we know that the biceps and so the supraspinatus and the infraspinatus, they have an insertion that is not the one that we in the past supposed to be. Some anatomical study given by Itoi, they say that the supraspinatus insertion is very close to the cartilage, and the infraspinatus is just distal, just lateral to that. And he showed us the spinatus fibers are inserted mainly onto the greater tuberosity, but some of these fibers they go transversely and they cross to insert to the upper lateral part of the lesser tuberosity. So somehow they contribute to the roof of over the long biceps. And when we have to fix the rotator cuff in the anterior superior lesion, fixing that part will help to manage the interior supraspinatus tear more easily. But we have to cut the biceps because otherwise we can get the repair, painful repair.
Yeah, we have another question from Dr. Swarnendra Samanta. Swarnendra?
Yes, Roshan, this is a great talk on anatomy because really there's too many things I learned from that talk. Thing is that Enrico, there is a request from me because every time we read from the Barkart's article that comma tissue, what is your take on that comma tissue from your anatomical perspective, and how the that comma tissue that Steve Barkart explained to us, that this comma tissue is very important during the repair and how you trace the anterior part of the supra. So from your anatomical perspective on that comma tissue.
Enrico, can you hear us?
So the comma tissue, that one, yeah. Can I?
Yes, Enrico.
Yes, it's audible.
Okay. So the comma is the part of the coracohumeral and superior glenohumeral ligament, along with those fibers of the supraspinatus. So if you cut the interval, so there was a technique that was supported by Steve Burkhardt in the past, probably around 2000, 2001. No, 2003 should be. Was the double interval slide. The double interval slide was cutting in order to repair easily or more easily the rotator cuff, cut the posterior interval between infraspinatus and supraspinatus, and cut the anterior interval between supraspinatus and subscapularis. But this for sure give you chance for repair, but you destroy the interior cable, and the comma as part is participated by the cable, and so you can, and some repair is given by a cannula or some instrument that goes medially under the cable, so medially to the comma, and pulls back the tissue at the corner, anterior corner of the greater tuberosity, so giving a stable fixation for the cable, for the coracohumeral and the superior glenohumeral ligaments, and for the remaining anterior fibers of the supraspinatus.
Yeah. So is there any other question to Dr. Enrico before we move on to the next talk?
Can I just a consideration?
Yes, Enrico.
Yeah. So for me, you shouldn't do the interval slide or the double interval slide, the single interval slide. If possible, prevent care not doing that.
Yes, Sanjay.
Since this is very different if you release the coracohumeral ligament off from the knee of the coracoid basis, because you do not destroy a connecting bridge that can can be helpful for fixing the rotator cuff. So when you have to release some, not into the lateral part, but into the medial part. So the coracohumeral should be maintained since it is very strong and thick, but you have to release it off from the neck of the coracoid, from the coracoid, in order to have a tissue gliding to be you able to fix that at the lateral part, at the close to the intertubercular groove. Thanks.
Yeah. Dr. Sanjay, you have a question for Enrico?
Yes. Enrico, excellent demonstration and commentary about the anatomy of the biceps. My question is, uh, when there is a partial articular subscapulary tear, do you believe that every time when there is subscapulary tear, the biceps pulley is damaged and then only the tear can happen, or without disturbing the pulley also subscapularis can be torn at least in the upper part, Lafosse 1 and 2?
I'm sorry, but I cannot hear.
Enrico, he just want to ask whether you can have the bicep
I
instability
don't hear.
without Enrico. Can you hear me?
Without a subscapulary lesion,
Yes, without
yes,
subscap.
it can. The long biceps can become unstable over, so not under, so not splitting or cutting the subscapularis. Yes, of course, but is I ask you, what do? Do you repair do you fix back the long biceps, or do you do anything different from
Sanjay,
that?
he want to ask what you do for such.
So I have occasionally found out that with upper subscapularis tear, biceps is still stable in the groove
Yeah.
and pulley is not badly damaged. In that situation, I just leave the biceps alone after debriding the inflammation around the bicipital groove and sheath of the biceps. But whenever I think about it, I am always in doubt whether I should have done tenodesis, because by virtue of tear in the subscapularis, this biceps would have become unstable or pathological.
I agree with you that anytime there's the subscapular, the long biceps unstable or involved in the area where there's some damage, you should fix the biceps. This not just because the subscapularis could be on down, but because there's a problem and you cannot risk for the patient to have a persisting painful shoulder. So anytime the biceps is exposed with no roof, the biceps is in a pathological area field, you fix the biceps. We can discuss about how to fix, but
Yes.
you should fix it.
I think we should move on to the next talk by Enrico. Enrico is going to speak on different types of tenodesis. Dr. Enrico, you can share your screen for second talk.
Okay. So, thank you. So, I will be short in this because I know that there's another speaker that would show in Tenodesis. So the problem can come from a single trauma, from overuse, and from aging. So pain is the system that gets the patient to the surgeon. Then we can have popping, clicking, other symptoms. What to do? So mostly in the past, in the very past, but in the close years, Italian, French, and some Europeans, they did a tenotomy. Why that? So in the 40s of the last century, the surgeons, they said that the long biceps was the cause of pain in the majority, almost all the shoulder problems. So the pain relief is of the tenotomy is very, very often obtained, but we have Popeye, variable the amount of the Popeye, but in the most about half or close to half, 2/3 muscle fatigue, so cramping, and especially we have fatigue, not just athletes, they obviously, but manual workers, and we have cosmetic problems. I know that ladies, they want to be, they do not accept to have that Popeye, since they have short sleeves dressing, so they prefer definitely a tenodesis instead a tenotomy. We have a number of tenodesis, as the tenodesis slide was given by authors. One of my close friends, Alex Castagna, did one. So the long biceps is fixed to the soft tissues as to the tendons during repair. So during the rotator cuff repair. Then we can have other type of proximal tenodesis with anchors, with sutures, and this maintains the part intratubercular part, so the path of the proximal long biceps with a pathology if there's an underlying pathology. So the other is the subpectoral transosseous. It is quite easy, but we fix the biceps very close to the muscle. And if we lose the fixation, if it happens something, we definitely lose any chance to revise the fixation. Another is suprapectoral transosseous. So suprapectoral over the pec major at the level of the bicipital groove, with holes, and holes can be half, so just a cortex, or the two cortex. When you penetrate both the cortexes for doing some endobaton-like fixation, you may have at risk several nerves, the radial nerve more than others. Then if you fix just in one cortex, you can do that by interference screw or by another mechanism that may be a keyhole mechanism, or again with a unicortical end button. So the keyhole is when you do a hole, the folded biceps pushed in, and down that you make a small through, so the biceps is captured by that. The screw, why I'm not favorable, I'm not a supporter of that. I did several, I did many in the past, but we have a very sharp, dense cortex, and we have a not a cancellous bone inside the diaphyseal cylinder of the humerus. So the pressure is concentrated at the level of the cortex, and that can, and screwing the interference screw, you can captive the biceps, and you can damage the biceps with a delayed rupture of that, or you can have a painful biceps, because it can be painful. Sometimes you may have nociceptors that are captive from that. So this is the one as shown by Laurent Lafosse, and now in the last, he supported another kind of tenodesis. We can say tenodesis slide, where he takes the interior of long biceps, proximal insertion of long biceps, and the anchor is larger than the entrance of the groove, so the biceps would be prevented to glide distally to the entrance of the groove. This is the pulley lesion, what can happen, and okay, we can fix the biceps if there's a slap, there's a pathology, just a biceps pathology, the superior labrum. But the most is when the biceps is in calf pathology. And so what we do is suture needle, a needle inside the biceps at mid path, midway from the insertion in the entrance of the groove. And so we can prevent the biceps from gliding distal, and we can do biceps tenodesis any level, having this to retrieve the biceps after the tenodesis. So here I was doing the biceps tenodesis by screws. I opened the sheet of the long biceps. This is in the intertubercular groove. This is the lateral ascending vessel from the anterior circumflex artery. I fix the biceps in order to have the biceps gliding. Then I open the groove. This is the groove. You see, as the groove in the superior part is cartilage, and it has not. This is the biceps groove, and I can fix the biceps. This is a key wire. I can fix the biceps by into the screw. After I debrided, I rounded the edges of the hole in order not having the edges too sharp, damaging the biceps. But this is what I abandoned, and I will show you why I abandoned it and what the two techniques I'm doing. So this events, as we, as the Italian Society of Arthroscopy, I chaired till I was the last chairman of that. We run every second year of shoulder and of shoulder arthroscopy. Thank you.
Thank you, Dr. Enrico. That was a wonderful insight on the different types of tenodesis and description of each one in detail. And we're going to know each and everything in detail from you as well as Raghuvar Reddy. Meanwhile, we have any question for Dr. Enrico on this? Anybody wants to ask question on his technique, current technique, which he's going to demonstrate later, or you want to know what are the different types of Okay, I don't think anybody has a question here. So, Raghuvar, can you share your screen?
Who? No.
Next speaker, Dr. Raghuvar will.
There's another presentation, is it?
Yeah, there is other presentation. Raghuvar?
I thank Roshan for this invitation. Are you audible?
Yeah. I'll just mute everyone. I'll just mute everyone, Raghu. Can you hear me now, Raghu?
Yeah, I can hear you.
Please go ahead.
Yeah, can you hear me? Can you hear me?
Yeah, we can hear you, Raghu.
Yeah. Thanks, Roshan, for again this invitation. I was told to speak on tenodesis in biceps groove, and in the particular part, I learned this entrance screw fixation by Sumant, and already etiology has been described in detail by Enrico. And in biceps, if nothing goes wrong, it is like a happy marriage, but it's like an appendix. If something goes wrong, it's like appendix, then you have a painful shoulder even after your best surgery. Go to Lickman. So why do people... Hello? Am I audible, Roshan?
Yes, you're audible, very much audible.
Yeah. So the functions of biceps are by it's controversial in the force, and 8% of flexion force is by biceps. So that you keep in the mind. So These are determines age and activity level, tendon quality, rotator cuff repairability, and cosmosis. That determines the what type of tenodesis, which level will be told by Enrico. And one more thing, I want to know about groove pain clinically.
समीर शेख चोर है.
So we have to palpate the groove.
Raghu, 1 minute, wait. Somebody is disturbing us. Wait, you just do one thing. You just go in annotation, your annotation. Just reveal the identity.
Do we have to just mute everyone else?
Yeah.
I go to more.
You have to go to more and reveal the identity.
Hide video panel, hide protein, share. The annotation spot is not there.
Has to be there.
No, it has been.
Before yesterday we tried.
No, Roshan has removed it.
Acha, but still somebody is speaking in between.
Yeah, in spite of.
Somebody is sending audio disturbance in between.
Yeah.
The charts we have to the chart box we have to close it.
Pradeep, Samir.
Yeah.
This is
Samantha
from Calcutta.
Yeah, listening to you, sir.
No. Thing is that somebody is talking in between in different language. I think Pradeep or who is the host, they can identify it, no problem.
Yeah, but Pradeep, you have to identify who is that.
I will try to identify. You go on with your presentation.
Go on, Raghuveer, please go ahead. Go ahead. Otherwise, we have to stop for some time, then we'll go ahead again. Okay, Raghuveer, you go ahead just.
Yeah.
Can we not mute everyone? Yeah.
So you have to palpate the groove. It's very important clinically. And if you want to confirm, you can do the axial rotation. The groove pain, it migrates laterally. So that is the sign of the groove pain. And these are the indications for tenodesis led by Yamaguchi. Age less than 55 years, spraying and atrophy more than 25%. And instability of the biceptal groove. And the patients who require supination force, like carpenters or even orthopedic surgeons and revision surgeries, and who desire to avoid cosmetic deformity, and you're dealing with flat more than 35 years. So these are the tenodesis. I don't go in the review. So proximal part tenodesis using a suture anchor was started by Habermeyer and Gottsman. Later Pascal started using the tenodesis screw. So I'll be speaking more on a bicycle groove, and the subpectoral is a more common. Intra-articular part is I use mostly in female patients who are thin. Those are the cases I use the intra-articular tenodesis. So I will speak on interference screw fixation, arthroscopic method. So how much you want our fixation should be strong? Should be at least 200 newtons. And if you see the strength fixation, these are methods of fixation: tunnel, interference screw, anchor, and keyhole. The interference screw fixation has got a maximum failure load strength, 243. And if you see the open subpectoral by interflexion screw, if you see here, this has got highest ultimate load failure with least displacement. Open subpectoral interference screw. Followed by, you can see the green thing. It is, again, ultimate load failure is almost same, but slight more displacement. Followed by open subpectoral tunnel and followed by arthroscopic suture anchor. These are the method and coming in the ascending mode. So strongest mechanically is interference screw. And why we do the tenodesis? Because it has got advantages. It maintains the length tension relationship. It prevents the atrophy. It prevents the, increase the strength of elbow flexion supination is maintained, evidence of cramping and cosmetic deformity. So I do in the beach chair position, and these are my anterolateral is my viewing portal, and this is my working portal. So these are my steps: tenotomy, and followed by localization opening of the bicycle groove, biceps exteriorization and preparation, drilling the socket and passing the tendon socket and fixation. So this is the intraarticular view. You can see the slightly
Samir Sheikh Chor hai.
Incision is not good, and this is the pasta lesion is there. I fixed. Now you can. I'm seeing the fix the.
Raghu, can you wait for a minute?
Yeah, sure.
Just hold for a second because it is too much for us.
Dr. Rajesh Rohila?
Rosen?
Dr. Rajesh Rohila, can you hear me?
Rosen,
okay, I have removed him.
Rosen, this is a request. Yes. Dr. Samantha speaking. Can you just hold for a second the YouTube stream and you just sorted this out? It is too much.
Yeah, I will just remove many people from here who are not known to me.
Yeah, some people are there without names.
Yes,
they can remove them.
Double Deepak Chaudhary, so I'll remove Deepak Chaudhary.
No. Whoever in the phone name, remove those.
I'll just remove it.
Stop the streaming and remove the whoever is not in the with the full name. They remove everybody.
Yeah, I will just removing it.
Stop the YouTube before and then you do the thing. Samir.
Yeah. We will.
We'll stop.
Just hold for a second.
Okay, I think I removed many. Let's go ahead.
Now it is 22 only. Okay, go ahead. Now it is complete 22 only. You can go ahead. Raghuvi, you just go ahead, please.
No
sorry.
Yeah.
Raghuvi, sorry from our side.
Oh, no. I'm audible?
Yeah, audible. Completely audible. Sorry to everybody from Rosen.
So this is the biceps incision. You can see this is a pasta lesion there. And you can see the biceps inflamed. I'm passing the spinal needle first, fixing the biceps. Then I'm doing the tenotomy. In the suprapubic space, I pass another spinal needle distal to it before making a portal. So first identify the previous spinal needle, make another portal distal to it. Then I'll open the bicycle groove. You can see that inflamed tendon in the bicycle groove. Now I remove the proximal pin. I exteriorize the biceps. And I pass the sutures. So I go very much distal, almost 2 to 2.5 centimeters from the proximal part of the groove. I don't go to the other cortex. So roughen the edges. Now I push the biceps into the socket prepared with the guide wire. I skip in around 30 degrees of elbow flexion. and I confirm that it is stable or not. That is one way of doing the interference screw. You can use the civil lock. Again, before doing tenotomy, ask the suture to have a grip to maintain. Means I'll tell you why I do this. When I do tenotomy, the tunnel is made. This is the biceps civil lock. So proximal end of the suture is pulled it. So to keep the normal human tension, length tension maintained. So the other suture. So the disadvantages are there. So it's slightly difficult. So to avoid the groove pain, I do the biceps tenodesis almost distant, most at least 2 centimeters below from the top of the groove. Of course, if you are not careful, they can have hardware and retear. All these things are there. Coming to this technique, percutaneous intraarticular trans tendon tenodesis, Habermeyer, Doroski. So I pass the PDS suture and retrieve it and do a tenotomy. This is like suturing to the capsule. Those two ends are blindly dotted on the suturing on the capsule. So it will be remaining to like this. Normally, if I do in female patients or thin patients, I don't want to do tenodesis. For the subpectoral tenodesis, this is my favorite thing. The guest speaker is going to talk to, and I don't go in detail it. Usually for young people, isolated rupture case, this is useful. Rehabilitation, I keep 6 weeks of passive. Only after 6 weeks, only I start active elbow flexion. So take home message is I will be doing in older and less active patients tenotomy. So indications are instability of biceps, pulley or subluxation dislocations, pre-rupture, slabs more than 35 is a region cuff. So arthroscopic biceps tenodesis when indicated using interference screw gives good clinical results. But position of the tunnel is very important. It should be at least more than 2 centimeters below from the top of the groove. That is very critical to avoid the groove pain. Thanks for patient hearing. It's open for discussion.
Thank you, Raghu, for wonderful talk. Any question to Raghu?
Raghu, I'm Dr. Samantha from Calcutta.
Yeah, I can hear Samantha.
Just one question to you. When you do your this in the tenodesis in the group part, how you decide your length? Because when you take out the intraarticular part, it is very difficult to know the length and what is your arm position, forearm position during that fixation. Yeah. Just for clarity and the answer, I just want to know that.
Yeah, I removed around 1.5 centimeter of the tendon. I cut it once I exteriorize the tendon. I cut it at 1.5 centimeter. And time of fixation, I see that the arm is maintained in 30 degrees of elbow flexion.
Okay.
We are doing interference screw. But if you are doing it civil lock, it is very easy. With civil lock, first you are tagging with the suture. Understood? When you are about to fix with the civil lock, you pull the suture inside. So bring that tendon to the normal insertion level. Keep there and fix the civil lock. Got it?
Okay. Because we follow that only because you told that because intra in the tenodesis and the group part is really problematic. Yes, we follow the rule of 4 centimeter from the muscle part. We do that is easy. But intra group part is really difficult to know the length of the tendon, how much to keep and how much to sacrifice.
Yeah, actually the groove part, the most of the pathology lies in the groove. And you see that if you fix the tenodesis proximally, still patient will have pain, cramping pain, all this.
Problem because if the pain is the problem, then patient will have the pain.
Yeah, that's why you have to do in the lowermost portion of as much just above the pectoralis major. You have to do it.
Okay.
Just
Raghu,
above the yeah.
do you see a very high amount of pain when you do this kind of procedure? And if you do it in the groove, below the groove, the incidence of pain increases or decreases when you do it without the groove?
If you do tenodesis just above the pectoralis major, that's why Enrico, the previous speaker, has told that suprapectoral tenodesis. So you have to go just above the pectoralis major, the groove portion. So if you are much more distally, the groove pain patients won't complain. But if you do it proximally or any tenosis in proximal portion of the groove, patient will have pain after the procedure.
Yes.
That's
Yes.
why I either do tenotomy or do the tenodesis at the lowermost portion of the groove above the pectoralis major or subpectoral tenodesis.
Okay.
Roshan, what is
Yes,
your
Sonal.
what is your choice of doing the this biceps tenodesis? What you do for?
Yeah. Many a time when I do it in non-athletic population, I always do it in the group, unless there is a group pathology which is diagnosed on MRI. If it is a athletic population and he requires a very strong grip and strong bicep, it's better to do the subpectoral tenodesis. That is better because association of pain is very less. What does Dr. Enrico does? Enrico, can you hear us, Enrico?
Yeah.
Dr. Enrico?
Samir, what is your take?
Yes, I hear. Yes, I hear.
Dr. Enrico, what is your choice when you do the non-athletic and athletic population of tenodesis? Whether you do it in the groove or subpectoral?
In a non-athletic population, I mean that out of the proximal part of the groove, it is enough. If you want to have a stronger care, because in the normal situation in the anatomy, the long biceps is not so stiff, so as we do by screw or by the subpectoral tenodesis. But however, subpectoral is a good option, but I moved for almost all the patients to do at the level of or just above the pec major. I can show you how. And so for patients that are not so, they do not request heavy work or heavy stability as I studied and I published a tenodesis that is done at the level of the pec major, and I called no odds pec major lumbar tenodesis. This because you fix by long sutures the long biceps to the biceps, to the sheath, to the pec major, and the roof of the bicep. So you pass the sutures through the pec major, through the biceps, you exit from the pec major, and you fix the suture. You just close the sutures, not the time knot. And so two of these, and you have the long biceps that is fixed in this anatomical position. And you, after that, you cut the biceps at the joint, inside the joint. So you know that there's not over tensioning, there's not under tensioning. So in the cases we did, and we compared with tenotomy, not versus other tenodesis techniques, we had no residual pain, no cramping, except for one that had the loose fixation. So now I moved to another technique that I can show in the next video, if you want, the one that was scheduled for.
Yes, I think if there is no question
Okay.
on
And
bicep
this is
tenodesis, anybody has a question on
also
bicep?
One question to Raghuveer.
Raghuveer, yes.
Yeah, he showed us capsular tenodesis, intraarticular capsular tenodesis. So anybody experience of having T or self-locking tenotomy versus capsular tenodesis or tenodesis, the results, and tenotomy versus tenodesis, does it affect, especially the Popeye deformity or Popeye sign?
So how often, Raghuveer, you do self-locking tenotomy described by Laura Lafos?
Generally, I don't do it. So,
You don't do it. Okay.
yeah, it means what he meant is you take the incision part, bigger portion of
Yeah.
it, so
Yes,
that
yes.
no need of doing a tenodesis.
Tenodesis.
Just doing the tenotomy, take some amount of labrum so that it will be it will stabilize at the groove only.
Yes, nodular tenodesis.
Yeah, it is right.
More or less nodular type. I never do that.
So how does it the pain chance because Mukesh?
I agree with Roshan because the patient might still complain of pain. So
Okay.
either you do, that's why initially I've seen some patients after tenodesis having more pain.
Yes.
Just do just tenotomy and leave it.
Okay.
Roshan,
yes, Abhay Narvekar, sir.
More often than not, please, I have done more tenotomies, and I think except for maybe one or two who have sort of come back with a Popeye, nobody has come with a Popeye. But one thing is sure, most of them are painless. That biceps pain goes better with a tenotomy than with a tenodesis, because I think to get the right tension for the tenodesis is a bit difficult. In slightly younger non-athletic people where biceps pathology has been seen, I have done basically just added the intracapsular stitch, so that, what is it, that TIF method? What is it?
TIP method, yes.
TIP method. So that is what I have done. But only when, rarely when we are doing the subscapularis and there is basically the biceps which is there in front of you, and eventually you want to use one anchor, one of them sutures, you put them through the biceps, that I do the biceps tenodesis using a suture anchor. But otherwise, most of this thing has been just a tenotomy. I think I've had just one or maybe two that I can tell you offhand who have probably come back with a Popeye and actually complained of a Popeye. So it's not
Sanjay, your practice? Sanjay Trivedi? Okay. So if there is no question, Dr. Anta wants to ask question. Dr. Anta?
Sir is there. Antav sir is there.
Okay. If there is no question, I think I'll...
just one more point. Also, it saves your half an hour to 1 hour of time if you do a tenotomy compared to a tenodesis.
Yes.
Tenodesis never takes half an hour. If you learn it, it's hardly 10 minutes.
Sometimes it may be very tricky, so it may be another
Yes,
15-30 minutes of your operative time.
So Dr. Enrico is going to show us his technique, and which is the most popular technique in Europe for doing transpectoral tenodesis. Dr. Enrico, am I right? You can share your screen, Enrico.
Yes, I can, but I can say this is not the most popular. This is a relatively new suggestion to do a tenodesis. We in Europe probably the most they do a tenotomy. We are so European are killer, and now we are moving to tenodesis. So European are so this is the technique. Do you see?
No. Please share your screen.
You see?
No, we can't see you. Please share your screen, Enrico.
Yeah. So okay. Sorry.
Open your presentation in desktop and then share your screen.
Yeah. So, just a moment.
Roshan,
Okay.
some French people
Okay,
tell that biceps has got no right to stay inside the joint. So at the end of the thing, I will ask Enrico on that.
Do you see?
Okay. Yes, we can see Enrico. I'll just mute everyone.
Mute audio. Is it mute?
Yes, moving, running. Movie is going on.
Okay. So let's show here the big major insertion, and we do a cutters. So it is 1 to 2 finger long the incision. Here there are small vessels. We go to coagulate the small vessels. And this is really how the extended the deltopectoral approach. So we don't go to the axillary crease as we would be at the subpectoralis, but we stay at the level of the pect major. And we move medially because the interval is medial. The deltoid is here, pect major is here, and here in this yellow fat, there's the axillary vein, the cephalic vein, and here you lift the tissues in order to have a separation between tissues. And you can, as you see, you can isolate the vessel and the pect major. You know that the pect major insertion is just lateral. The tendon is over the greater tuberosity, over the long biceps groove, and just lateral. So you can follow the pect major. You have not any risk, but if you follow the anatomy, and so you can extend or do anything you want to follow that. Okay. Now you know that the groove is lateral, and so when you will direct to the groove, you should tilt any instrument to go lateral, because straight going to the back, there's the axilla, and axilla has many enemies. But if the surgeon knows the enemies, there's that risk. Okay. Now you release all the pect major off from the deltoid, and this the cephalic vein is the forceps, and I direct the forceps toward the lateral part, so at the level of the insertion of the pect major. Look at this is the pect major insertion. There are the ascending vessels, and okay, this is what I told you before. This is an ascending vessel. Okay. Giulio Vini is the colleague that in this time I asked for to perform the movie. He's a shoulder surgeon, but now as a filmmaker. Now, look at, I cut the tendon in the same orientation of the fibers, the tendinous fibers of the pec major. So just a hole, and this is how to, in this way, the fibers would close back with no need of any suture. This underlying is biceps. This is the long biceps. So we are splitting as a subscapulary splitting. This is a pec major splitting. We know that there is the biceps. We can do in two ways. We can suture the biceps and the pec major in at the same time, or we can, for people that are much they have requests for strength. We can do this, that is the fixation inside the humerus with just suture anchors. So no, there are no holes, but just this 2.3 or 2.7 hole and 2.3 suture. And you can at this time do by an arthroscopic similar way, or directly by a needle, so in an open-like way, the suturing. And this is so I will do this. So I show you I can do a nice knot, and this holds the first suture to the tendon. So I enter into the loop of this, and I pulling on to the two limbs. I can fix the first long biceps. Then I can do all the stitches, the same suture, running suture, going and back, and then I can close the pec major. I can say that it is an echo. This is the final view of this tenodesis, and I can say that we can then do a subcuticular point, and then running internal suture. So this is the technique. This is one of the techniques, and the one that I suppose I advise as no jeopardizing the pec major, no giving problems to the humerus and so on. But it is one among other. Okay, I can stop. Okay, so we are going to the end of the meeting, I suppose. Is it?
Yes, thank you, Enrico. That is a wonderful demonstration of transpectoral bicep tenodesis. Any question for Dr. Enrico before we end the meeting?
Can you get my videos, my camera start, because you so not to be hidden.
No. Actually, your internet is not very strong, so that was the reason why
okay.
So I'll just make your camera start again.
Okay, super.
Dr. Enrico, may I ask you a question?
Yeah.
What
Yeah,
is the
definitely.
what is the average number of tenodesis you do in a year in your shoulder practice?
It is, I cannot say the number, but I can say that is in 70% of the shoulder uh, uh, cuff repair. So
Okay.
if not me, if there's a supraspinatus tear, but the lesion is not involving the coracohumeral, the interval. I don't do and the tendon looks healthy. I don't do anything.
Okay, anybody has a question? Raghu, you do a transpectoral or you below the subpectoral?
Yeah, subpectoral version. I just wanted to show if you have a video,
Yes, yes, please go ahead.
because if you have a acute rupture
Okay,
in the young people,
yes,
subpectoral method is much easier.
okay. So you can share your screen with video, no
Yeah,
problem, Prabhu.
yeah, but rarely if you do in the cuff part, you do all the rotator cuff surgery. Towards the end, the shoulder is lot of
I mean,
swollen. You can still do the subpectoral method, which is much easier.
Okay. Can you share the video? How many people here do subpectoral tenodesis? Samir, Manoj, Deepak Chaudhary sahib, subpectoral tenodesis?
Kosan, I always do subpectoral.
I also always do subpectoral. What about others? Other faculty?
Sometimes subpectoral. I am one of the old timers along with Dr. Abhay and Nicholas who do full of anatomies. So,
Tenotomy. Okay. So, Dr. Manoj?
You can see my screen?
Yeah, Dr. Manoj Mehta?
yeah, speaking.
So, what do you do? Subpectoral or
No,
in the
occasionally.
groove?
Occasionally.
Occasionally. So, I think more or less we are in the groove tenodesis people and we don't do subpectoral. So, let's understand from Raghu. Raghu, go ahead, please.
No, I just have one video. So you're seeing my screen?
Yeah, we can see. Just make it slideshow.
Yeah. So this is the incision we give.
Make it slideshow, sideshow.
Yeah, because next show I will go to the video.
Okay.
That's why so we are going in between. They are lifting the deltoid. Okay.
Okay.
And coracobrachialis down. Shortness in this area. And can you see the video?
No, we can't. You have to start playing.
And then
you open the video in your desktop and then share the screen. Open the video in your desktop and then share the screen.
I mean, the subpectoral tenodesis is, however, super profound. The strength of fixation.
You're seeing now?
Yeah.
Hmm?
Yes,
You're
yes, we
now?
can see.
Yeah.
Yeah.
Because I was not prepared for that. So I'm
No
just
problem.
showing. Yeah. So on the spike on the deltoid.
So can you orient here? Which one is pectoral muscle?
this is you are keeping under the deltoid, and this this is the anterior, this is the posterior.
Okay. So this is right shoulder.
Yes, right. This is
Right
posterior.
shoulder picture position.
Yeah, supine. Yeah, supine, and this is the anterior. This is the posterior.
Okay.
Yeah. So you can see that is axilla. Yeah. So even the shoulder is swollen towards the end of the surgery also, you can do this.
Raghuveer, is that posterior spike safe?
Yes, yes.
Because generally you would see people using a retractor posteriorly rather than using a spike posteriorly. Anteriorly, yes, because you can then take the pectoralis up.
Yeah, pectoralis.
But I think I'm not too sure about that posterior spike.
And just near to the bone. Just adjacent to the bone.
Yeah. I think the technique
Because
is very easy, Raghu.
musculocutaneous nerve, etc., comes there. So you could stretch it out.
The
musculocutaneous nerve is behind your spike.
No, there's no other important structures there nearby.
Musculocutaneous nerve, because your coracobrachialis will come from there with the musculocutaneous nerve, and that is there posteriorly behind your spike.
Yeah, but I keep, yeah, you may be correct, but I just keep just adjacent to the bone and just keep the spike.
Okay. Yeah.
Okay. So I think it's a very good technique, Raghu. Thank you very much.
Yeah.
I think if there is no question, we should thank Dr. Enrico. Enrico, can you give us a last message, your last message? Enrico, can you hear us, Enrico?
Yes, last. Yeah.
On bicep tenodesis, how you...
My last message is for doctors that are going deep into the shoulder is echography should be the tool that would improve profession and give help earning money in a right way. Then the shoulder tenodesis, long biceps tenodesis, the stronger part is the under the pec major, but consider that at level the pec major it can be done, and you can use the pec major tendon as to fix the long biceps in a very costless way because few sutures long-lasting resorbable sutures and so very cheap way can be done at tenodesis and this is one part of the pros, but